The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Today's LymphCast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Welcome to LymphCast, the show that brings together doctors, other health professionals, and special guests to discuss lymphedema, venous disease, and other associated disorders, and what can be done if this is affecting your life. Now it's time to sit back, relax, as it's time to learn all about lymphedema, venous disease, and associated disorders on our show, LymphCast. Greetings and welcome to our LymphCast show, episode 18. Whether you're listening on the podcast page or watching and listening on YouTube, we are glad you are with us. A lot of great information tonight, but let's meet our panel first. From Arizona, Dr. Monika Gloviczki. Greetings, Dr. Gloviczki. How are you?
Thank you. Hello, everybody. I'm so happy to be with you today. And of course, welcome to Annika.
All right, very good. And from California, Dr. Emily Iker. Hello, Dr. Iker. How are you?
Hi, everybody. Welcome from very cold California. We had 41 degrees this morning, which it's freezing for us, but no rain and sun is shining now. So with that, I want to say hi to everybody. And Annika, we are honored to have you here today.
All right, very good. And the founder, creator of VitaSupport MD, makers of Vein Formula 1000, Lymphatic Formula 1000, also the creator and founder of this LymphCast show from New Jersey, physician, surgeon, Dr. John A. Chuback. Hello, Dr. Chuback. How are you, sir?
Hi, Paul. I'm doing great. Thanks very much. It's good to see you all again. We're hoping that eventually here in New Jersey, it'll get up to 41 degrees and looking forward to those warmer days when we get above the freezing mark. So it's good to see you all.
Yeah, we don't have a lot of sympathy for Dr. Iker, do we, Dr. Chuback?
No,
I didn't think so.
We have a lot of admiration. We have a lot of respect. We have a lot of envy. Sympathy is not one of the words that comes.
Okay. All right, sir. Would you like to have the honors of bringing in our special guest?
Yes, I would be pleased to do that. I'm going to do my very best. Unfortunately, I'm filling in a bit for our esteemed colleague and co-host, Dr. Mark Melin, who is, as always, traveling, educating, teaching, and I believe he's on his way back from an important conference right now in Boston. So he's traveling. He sends his apologies to everybody. Looks forward to seeing us all again very soon. And quite frankly, Annika is Mark's primary guest. Of course, she's a guest to all of us, and we're all happy to have her here. So I'm going to just read a little bit from the notes that I have. Annika Kariniemi or Kariniemi? First or second?
Yep, Kariniemi.
Kariniemi. Annika Kariniemi earned her bachelor's of nursing degree in 2008 in Helsinki, Finland. And immediately after graduating, she began her career working in a vascular and wound clinic, which was, as I understand it, part of the Helsinki University Hospital system, as we all know, is a very, very fine institution. And in 2018, she graduated again with an advanced degree as a family nurse practitioner. And she's had a great passion for wound care. And this has led to her board certification in wound care in 2019. And since that time, she has moved to Flagstaff, Arizona, and she's recognized as an she recognized an acute need, a very severe need for wound care services in that community. and opened her own clinic, which I love to hear about how that was done and how that's going in 2020 to fill the need in that community. And she now has Avella Wound Care, which is serving patients in the Arizona area of the Phoenix metro area, as well as northern Arizona and the Flagstaff area. So welcome, Annika Kariniemi, and we look so forward to hearing your story and learn more about what you are doing to serve the community in which you live. So welcome very much.
Thank you so much. I appreciate the introduction.
You're quite welcome. Is there anything that I got wrong or anything that you'd like to add?
No, it's absolutely true. Moving to Flagstaff in the kind of in the thick of COVID, so to speak, and realizing that there is a severe need for a wound clinic. The only wound clinic that existed there was one at the hospital that's run by PTs, and I definitely toured them and would have loved to work there, but they don't hire providers. So I kind of had started the groundwork of funding my own business, and that's what I did. I actually ended up getting my first patients before even having an office space, which then led me to walk into a podiatrist's office who this patient was mutual with. And I said, hey, if you have any rooms, I would love to lease and see these patients. And sure enough, to this day, we still work very closely together. But that's where I kind of started. A couple months later was found by an endovascular group who wanted me to kind of come into their office, and they sent 14 referrals as a fax, as a kind of a welcome. And I was like, all right, there's work to be done. So that was amazing. And I certainly view myself as only a part of an interdisciplinary team that we need for wound care. And I don't think wound care can be done alone by anyone, any specific specialty. So working together with good partners and amazing professionals is what I needed. And so this endovascular group then later invited me to see their Phoenix patients as well. And that's what led me to here, where I'm actually now at the Phoenix, my own Phoenix office that I later arranged. But I started kind of inside of their office and seeing mostly their patients, but certainly the word got around. And as my website got to be on the more, easier to find, we kind of grew there. So what we do, I would say we have very much a team approach. We pride ourselves in care coordination and definitely a hand holding of the patients, and kind of my whole team does that. So anyone that we hire acknowledges the fact that our patients are already very underserved, and the fact that they walk in our door seeking help for their wound is a big step that they have now taken, and we take it from here for sure. And I assure all the providers who refer to us that their patient is in good hands. So as a team, we take some parts of it, but we certainly need the other providers that are part of the team. But I would say we do ulcer debridement, ulcer dressing, nutrition, pressure offloading, edema management. We work together with vascular groups to make sure that the vascular supply is there, identifying, managing infection, and then obviously partnering with family practice very closely to manage the comorbidities that the patients have. Venous intervention, working together with derm when there's issues that derm can help us with.
Because I know it's a little bit different state to state. Where you are in Arizona, are you practicing independently as a nurse practitioner? Do you have your own freestanding practice, or do you need to work under the supervision, for lack of a better word, or license of a medical doctor?
We practice fully independently here in Arizona. So no collaboration there, but definitely lots of collaboration with physicians otherwise around me. And Flagstaff is a small mountain town, just 2 hours away from Phoenix area. We're at about 7,000 feet elevation. We serve, as a medical community, we serve the population of 700,000, although there's only 74,000 in our city. And patients come from all the way from Four Corners, 4 to 6 hours away, long commute, and using transport. And definitely a very underserved population that is very remote. Lots of my patients don't have electricity or water.
Wow, that's quite amazing. You know, I know that the other company which I'm involved with, Vita Support MD, we recently and I'm not bringing this up to to highlight that because I want to learn about it. Actually, we recently helped to support an event that you were sponsoring at your clinic. And we were very happy and proud to do that. Can you share with the viewers and listeners what that, I believe that event has now taken place, if I'm not mistaken, but can you tell us about that event and what it entailed?
Yeah, that event is called Wound Care Skills Fair. And it actually was supposed to occur tomorrow night. And we have had a huge snowstorm. We've so far had 60 inches and more is about to come. And we had to postpone it just because the snow conditions do not, I mean, most of our reps were coming from Phoenix and they will not drive to that snow, and the driving conditions are extremely dangerous tomorrow night again. So we had to postpone that, and we cannot wait to have that because we got 68 RSVPs, and it's been an incredibly needed event. Our goal was to serve kind of our home health partners who are taking care of our patients at home, and they pressure wrap our patients and they change the wound dressing. We were kind of hoping to give them help and assistance in how we do things and maybe just open up that collaboration and kind of know what each other do, although we do work together a lot of times just over the phone and in the rush of everyday life. So we were targeting kind of to try and arrange this for home health. Then became, the skilled nursing facilities staff wanted to participate. And then of course we invited all of our doctors that refer to us, who collaborate us on the weekly basis. We invited them, and we kind of picked the best, our favorite products that we work with that you see in my orders every day. So these professionals can find out more about the product and maybe even hands-on get information and instruction on things. So I was starting to get infectious disease. I was starting to get podiatrists to sign up. Then the trauma surgeon signed up. And one of my patients, who was a mutual patient with this trauma surgeon, said that he would really like to attend. And of course, we invited him as an honored guest. So we cannot wait till this event can happen. It has been so exciting to kind of work around and show what we do in wound care and how we can help together. And it's a pleasure to me to offer these kind of collaborating moments to all of the nurses in the community.
Well, I think that's amazing, and obviously you're putting yourself apart from the crowd as a real leader in your community in wound care as a specialty, and which it obviously is. And Dr. Mark Melin, our esteemed colleague, has devoted his career to this very, very important undertaking of the management of, as you say, and Dr. Melin says, the wounded patient. And these patients obviously are wounded, and soon we're going to be adding to our discussion a new co-host, Jacqueline Sasek, who worked with me for many years here in my clinic, who's a RVT and an RPHS, but also has a background in therapy and so forth. emotional therapy and psychological therapy and so forth. And we're talking also how these patients who are wounded with a physical wound, how they're also, in some cases or many cases, I won't say all, but can also be wounded emotionally and psychologically, to have to live with an open wound in many cases for prolonged period of time. So first I would ask you two-part question. One is, how often are you seeing your patients in your clinic for debridement? Is it weekly? And then also, if you would comment for us on your take on the emotional and psychological aspect of the wounded patient.
Absolutely. How often? I prefer to see them weekly. I have some that are due to usually reasons that arise from their living situation and ability to make it to clinic. We do have at 2 weeks. Weekly debridement is essential for a lot of them, just simply even from the standpoint of kind of watching and keeping eyes on that wound and trying to see if it does turn to worse. I do promise my patients who live further away that as soon as I feel that moment is over, I do switch them to a little bit less. So that's kind of the frequency. My nurses do touch base with them a lot more than that. There's a lot of calls and triage that goes on behind the scenes, and that's definitely, I want them to feel that way. Now, the psychosocial component is probably one of my favorites, just because we do pride ourselves in kind of standing strong on that. So patients who, wounds are always a crisis. When a patient has a wound, almost always those referrals that I get at noon on Friday, guess what? They want to come in before the weekend, and they want to be seen right now. Whether there is long comorbidities that have been with these patients for a long time, it's still always something that is first psychosocial challenge. And when I look at these patients and assess, we very much assess the kind of the 6 areas that we really find that, according to research, are often present in a wound care patient. So sense of self-identity, they may feel that they have almost lost themselves. Self-confidence, they definitely don't feel confident in carrying out ADLs and just want to hide away in social situations. One of my patients from the Indian reservation, she said that she has never shown this wound to anyone in her family. Her family brought her to the visit, and she has improved significantly from that moment. And I think also psychologically, because now this long-term hidden problem has been addressed. Future dreams are definitely affected. They don't feel that they can dream of future. Sense of hope, very discouraged and hopeless, as the wound is not often progressing for whatever reason. And then they have struggled with losing the meaning of life, and they feel like they're rather surviving than living, as well as self-belief, which they are very critical of themselves. And this is not a time and place when we kind of dig into all of those maybe neglected health conditions that we, for some reason, have been pushing away. We try to address this moment, and so often the patient already feels better just from that. So the first visit is very much a dressing and cleansing, teaching visit, as well as we initiate the compression and good nutrition and everything like that. And then the second visit is more so diving into how are we doing, and who, and to identify even simply who helps you with wound cares. Do we need home health on board? Almost always we do. Indian reservation, it's hard. There's only one home health company that goes to my very most remote patients, and they only go twice a week. So there goes my frequency of wound dressing changes. But we deal with all of those and kind of tailor that plan to the patient.
Vein Formula 1000 and Lymphatic Formula 1000 from VitaSupport MD are backed by science and sold in doctor's offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
So can I ask you, first of all, I'm very curious. So how large is your group of nurses?
There's 7 of us. So there's,
Yeah.
I have medical assistants, and then I have certified wound nurses in both clinics. And then other staff, obviously front desk and admin. But there's 7 of us total. We just work with home health groups that help kind of with the care at home.
Yeah. So you are in the office, but you have also the in the network of the nurses going to patients' homes.
Yeah.
Right.
Yeah.
And the other question that I had, so how you organize the cooperation with the with physicians of diverse specialty, because this is so crucial in the wound care to have the correct diagnosis, to have the correct treatment for the pathology that is resulting in wounds. So how you organize it?
Absolutely. I play a lot of phone tag with physicians. Mostly it is having the people that I work mostly with do know, and we connect on those points where something didn't translate right, or the referral note didn't quite have all the information, or give a little warm handoff of a patient. We do that very often. Sometimes it is our nurses that help kind of connect the two and try and relay the most important information.
So you're working with the vascular surgeons?
We actually, in Flagstaff, we only have vascular surgeons kind of on call. It is a group. Obviously, vascular has to be covered just because it is a trauma level 2 hospital. However, it's often handling trauma 1. And with the endovascular group that I work very closely with, I can get the patient into a direct angio if there is a need. And quite frequently, actually, I do get that, where a patient has a cold foot and we have to do something quickly. So ultrasound and waiting for an ultrasound to be scheduled is not sufficient. We get them into direct angio, and most of the time, once we get that occlusion resolved, we obviously can kind of begin our work. So kind of prioritizing that as well. So some patients, revasc is the number 1 thing that they need, and we don't mess around. So it almost doesn't even matter what you do until then, because that needs to happen, right? Putting good wound care products and non-cytotoxic cleansers and all of that is obviously what we start from the beginning. But really, if blood flow is an issue, I need every drop that I can get to that area. So working closely with those partners is absolutely essential for me.
So, and do you also have the contact with the dermatologists or other other medical specialties that could be helpful around the wound care? Mm-hmm.
Yeah, I work closely with infectious disease in our hospital, just because they often have patients that they don't quite feel that they need maybe an admission and a long hospital stay. And our little hospital is also stretched very thin at times. So working together with infectious disease, working together with podiatry surgeons, all of that is what we do on the daily basis. I wish I had great coverage for lymphedema therapy. So with this podcast, I want to extend that. If any lymphedema therapist is looking for a place to live, Flagstaff is beautiful. kind of having that whole team around me, and them knowing what we do and us knowing what they do is essential.
Yeah, we were talking just recently together about the complexity of treatment for patients with lymphedema, because it looks like that most of the time, even if you have the lymphedema specialist, they don't accept the patients with wounds. So apparently there is the issue that very often they are they don't want to deal with the wounded patients, and that's a pity, because obviously there is a good result for the wound healing when you address the issue of lymphatic insufficiency.
Correct.
That's for sure.
Absolutely. That is so often the missing puzzle piece. It's such an honor to get a patient that has maybe tried many different things. I look through them every once in a while. I get one like this, where kind of a lot of very advanced things have been tried. And I go, well, have you ever worn compression or anything? Has anybody ever addressed the swelling? And we start that, and we see just miracles unfold in front of our eyes. And same with nutrition, just fixing a couple little things and helping, and some patients telling them that, you know what, wounds are not actually your biggest issue at all. I know they seem like they are right now, but if we do a referral to bariatric surgery or bariatric medical doctors and get help on that side, as well as address diabetes and then address the swelling, we may just end up fixing your wound problem or the recurrence. I tell the patients often that, you know, I can heal this wound, but if I don't address the underlying cause of this wound, I am of no help really to you, because you're going to be at my door again. And while we love to have you here, we want you to be done with wound clinic, right? And so I always say that I'm looking for the missing puzzle piece, so to speak, with wounds. And for someone it's compression, and for someone it's revascularization, and for someone it's getting them to a safer place with offloading and all of that. So, but so often it is compression, and that's why we actually do use the lymphedema supplement in our clinic. And I have patients, I just had a patient who ended up moving to North Carolina, back to where she's from, and she keeps calling us to send her some more lymphedema supplement. She knows that she can get it from online, but she still calls us. And to me, it's such a win when a patient, I have this male patient here in Phoenix who told me that I'm not wearing compression. I always wear shorts. I wear shorts year round. I'm not wearing compression. I often put them in edema wear, something that I probably picked up from Dr. Melin. It's such a versatile compression option for patients who should be wearing 30 to 40, yes, but if they're wearing 0, it's of no help, right? So I try to get them in edema wear. So I got this patient into edema wear, and long story short, his wounds were long gone healed, and he came back to my office and said, I need 4 more pairs of that compression. And I just thought, you know, we made a difference, because he no longer gets wounds if he just takes care of that swelling.
Well, you're obviously making a great difference. And since we're on this subject of lymphedema, I happen to know someone around here who knows a little bit about that subject, Dr. Iker, who's busy in her clinic and running in and out of the frame. So I hope we can keep her for a moment or two. Dr. Iker, do you have any questions or comments or discussion for our...
I want to compliment you, and I want to bring your residential area closer to Santa Monica. But I have a private clinic, and I do not only lymphedema management and lipedema, treating and lipedema patients, but I just had a lovely gentleman who had phlebo lymphedema with open wounds. And we do take care of that too. I have a wonderful staff, but when it comes to the wound problem, I do the debridement, and I usually give them a piece of wood in between the teeth so they don't scream. No, just kidding.
Yeah,
And
right.
and after the debridement, we are utilizing all kinds of different dressings according to the patient medical need. And it is such a joy to see them getting better, not only from the wound and point of view, but also from the lymphedema treatment. And compression is the key. And I want to compliment you that you are looking at the patient as the whole picture, not just the wound, because you are talking to them about the diabetes and the nutrition and everything to make them better, especially in the residential area where you are, where they don't have the water sometimes. It's challenging how you clean the wounds and how you take care of your hygiene, etc., etc. And that is so important. And most of the older population, male population, and I'm not a chauvinist, but the ones that they are living alone, they take a shower and they don't clean it between the toes.
Mm-hmm.
And frequently you see fungal infection in between the toes, which then moves proximally, and then you have open wound and it's delayed healing, and so on, so on. So the basic hygiene points are so important. And a combination of the factors, yes, that you teach them about nutrition and teach them about enhance the protein intake, teach them about the hygiene and diabetes control. That is such a strong point for them getting better. So my compliments that you are doing fabulous job. I have one more question in terms of billing. Do you accept Medicare? What kind of a billing do you do? As a nurse, are you allowed to bill Medicare, or do you have billing company?
Yeah, I have a billing company that I use, and they have been amazing. We do take Medicare and lots of plans that are kind of prevalent in this area, and whenever we run into a plan that's not covered, we absolutely try our very best to get in network. So we are under a pretty good network. We also belong to the ACO network of our hospital system there in Flagstaff, which gives us a good amount of covered networks as well. So that has not been an issue. So we bill Medicare because I'm a nurse practitioner.
Yeah, and Emily, let me jump in there. I don't know if you were there earlier when I asked that question, but it's very fascinating because every state in the country is different. In New Jersey, we do not have at this time nurse practitioners working fully independently with their own practice, but in Arizona they do. So Annika, as a practitioner, a nurse practitioner, has her own practice and is billing just as you and I would as a physician. And I think certainly we're going to see more and more of that trend in the coming years until it's obviously across the whole country. And so that may be something you did not hear earlier in the show.
Maybe at the end you can post your business card for everybody to see, because from time to time, I have patients coming from everywhere. And it would be so much easier to, after I diagnose them, and then refer them to their closer residential area, and they can see you there.
Absolutely. Happy to do that. Yeah, we as nurse practitioners obviously get like a percentage rate of the Medicare fee schedule just because it's built for medical doctors, but depending on the contract, it's between 60 and 80% of the code. So that's how it kind of works. But I certainly would not want to do billing myself.
I have to say that I admire your entrepreneurial spirit and the courage, because to establish the private practice coming from Europe, I totally lost with the all this system, Medicare, Medicaid, all the arrangements that exist here. It's still, for me, like a not
Very
understanding.
different.
Yeah.
I have a question for Dr. Iker and Dr. Gloviczki, because they've traveled so much internationally related to conferences, education, and so forth. Have either of you been to Helsinki, to the university where Annika trained?
And no, you know what? It's interesting because usually the European group of lymphology prefers Italy, which I don't mind. But the next Congress, the World Congress of Lymphology, is going to be in Genova. And I was just looking at the dates, and it's so interesting because it will be just 1 week before American Venous and Lymphatic Society meeting in Miami. So I would have to combine those two together, because definitely I want to be at the World Congress of Lymphology. And in Genova, Dr. Hakan, who is my personal friend, sent me a picture of us getting a picture together in 2001. And I was looking at that picture and said, oh my gosh, and this was in Genova. And I said, we were so young. And now, few moons later, there will be a Congress in Geneva again. So I'm really looking forward. And right after, we all meet in Miami, and hopefully the weather will be good and will cooperate with us in September, so we can continue our beautiful meetings there.
Yeah, and I have to make a little sneak preview that thanks to Dr. Iker, we're going to have, I believe, Dr. Hakan as our guest here on the LymphCast program, which would be wonderful. How about you, Monika? Have you been to Helsinki?
No, unfortunately not.
I'm surprised. One place in the world you haven't been.
No. But we were just discussing previously that, a very good friend of ours, it's a vascular surgeon from Finland that we love very much. So we will find if this is in the common connections, because Annika didn't know that person, but we will find.
I would love if Dr. Iker was closer to me, because I definitely struggle with finding those toughest lymphedema cases. I mean, they come as a challenge for me, definitely, and I continuously want to learn more so that I can fill those gaps that are there. And I know that I'm not everything for these patients, but gosh, sometimes they choose to come to the wound clinic. We had this one patient who chose to just not see cardiology, not see pulmonology, not see her PCP, just come to the wound clinic. And there you go. I don't certainly try to manage those conditions, but to try to kind of use that and leverage that relationship with that patient to try and have them see the specialist that they desperately need. We all have to work together. I mean, if they listen to me, then let's talk and get you into cardiology, because you have missed many years here. So.
You can send me a picture of the patient and we can communicate, or you are welcome to come and learn from me.
I think it was very intentional, and it's at the core of what we're doing here, which is to not only share knowledge with our listeners and our viewers, but with one another, that each of the physicians and the practitioners and the therapists and the patients who appear on the show, everyone is a teacher and everyone is a student, and every day is a school day, in my opinion. And we're sharing with one another and building new relationships. And these, Mark Melin is such a great relationship builder. In my life, I've known some incredible relationship people, but no one like Mark Melin. He puts people together and connects people like no one I've ever known, and it's quite inspiring. But these relationships, I know Dr. Iker, when she offers her services in terms of looking at a patient, sending a photograph, phone call, email, visiting her, is absolutely sincere. And we're finding that with all of our colleagues that we bring into the program. And I think it's one of the great aspects of this show. Now, speaking of education, I always like to involve our host and our announcer, Dr. Paul Reeves, because he has a very strong background in education. And he's our quote unquote layperson who does not have a clinical medical background, but he always asks great questions, I think, of our guests because he's looking at it through a different set of eyes. So, Paul, do you have anything you'd like to add or ask Annika what you've heard about so far?
I sure do. And by the way, Dr. Chuback, I will be entering medical school next week, strictly to have lunch, just to have lunch, and then I'll be leaving. But I want you to know I will be in medical school.
Don't forget, the cafeteria was my strongest classroom.
That's right. Yeah, Annika, a couple of questions for you. Now, obviously, you're a registered nurse, and a lot of people become registered nurses, and they have happy careers, and they enjoy doing that for the rest of their working lives. But you became a board-certified wound specialist. So my question is, what led you to that, to specialize in that? Was work availability, or just something you had a special desire to do? Just out of curiosity, what led you there?
Yeah. Wound care was definitely close to my heart already from the beginning of my nursing career, although my majority of my nursing career I did in the surgical area, pre-op, PACU, recovering patients, obviously dealing with wounds there as well. But I think I trained, I got certified and graduated as a nurse practitioner, got certified in wounds in Minnesota, and I was working for University of Minnesota physicians at the sister campus of Dr. Melin's practice. And it is definitely there where my eyes open to how complex these issues can be and how fascinating it is when you find those wins along the way and see that granulation tissue develop and this patient have a complete change of life from going to the wound clinic very frequently and dealing with this wound in their lives. That's where my and then through the certification of the WOCN program, which is kind of the gold standard for nurses to certify in wound care, together with the amazing mentors that I had, I wouldn't be here today if it wasn't for that.
Okay, and also a semi-related question. I still work with a lot of young people in high school and early college, and a lot of them tell me they'd love to know what jobs are available. You know, for example, registered nurse, everybody knows that, but not everybody knows a wound care specialist, that it even exists or what they do. Is that a field that's reasonably wide open right now, or is it fairly filled? Is that something younger people should maybe look toward doing if they're looking for a more lucrative career down the road?
Yeah. Going through the nursing route is certainly one route. Obviously, we have physicians over here that are you all have gone through a lot longer route, and to get that touch to patients in either whether it is family practice or nursing in the hospital or in outpatient areas is definitely helpful in kind of facing and meeting these patients where they're at. But so how a person would end up in the wound care area, there's a couple different routes when I consider my medical assistants that can certainly get certified through an agency. WTA is the WOCN organization holds for also just medical assistants, and then nurses go either through the experimental route or the program. So those are kind of the two routes, and they're definitely worth it.
Okay. Now, do you have to get a degree in something else first before you enter becoming a board certified wound specialist, or can you just dive right in and take the program as is?
WCN is only for nurses. And I first became a nurse practitioner in practice and family practice, and then went from there to certify myself as. So it is only available through being a registered nurse first, and then nurse practitioner for the provider part.
And generally, Paul, I think I would say, at least my knowledge, and Annika can fill in the gaps for listeners, because I think this is a very important subject that you brought up for young people, or even people who are maybe looking to switch careers and so forth. A registered nurse and the nurse practitioner are in many ways very, very similar, but there are differences as well. And I think the two major differences that stand out in my mind is that a practitioner can prescribe, generally, they can prescribe medications, including narcotic medications when necessary, and they can also order diagnostic testing, and they can obviously treat patients. Nurses generally, who can be extremely, extremely capable, knowledgeable. When I was doing open heart surgery, for example, cardiac surgical ICU nurses are quite extraordinary people and can do incredible things, but they can't write orders themselves, and they can't order tests themselves. So that, I believe, is one of the major differences that turns somebody from a practicing registered nurse into a practitioner. So, Annika, do you have anything to add to what I've said there?
No, that's exactly right. Yeah, I feel that the need to order diagnostic testing and need to order medication is so frequent that it definitely comes in handy to be a provider in this area. However, we have lots and lots of WOCNs that practice in the hospitals, and they do exactly that same work from that same foundation as I do, and understanding those basic principles of wound care, from non-cytotoxic cleanser to absorptive dressings and non-occlusive dressings, and all of those things that we consider when we try to kind of treat that wound specifically to that patient's needs, is kind of where you have to stop along the way many times and go, oh my gosh, the order of things just changed over here. And so getting that call, like, was it a week and a half ago, I got this call from one of the orthopedic surgeons in town, who says, Annika, I have this patient in my office, I just need some advice. And they said, I need to operate on their shoulder, but they're having so much edema that I can't even bring them in the OR. There's not much of a wound, but I really, really need this cleared up before I can take this patient in the OR. And I should have already had them there yesterday. And to assist each other in this way is just incredible, to get that swelling down and help them.
I just had one last question. I'll turn it over back to the doctors, Annika. In terms of what you do before, do they have to come to you first for the wound care before they can even see a vascular surgeon, or do you work at the same time in conjunction? Or what's the pattern of caregiving at that point when they first come in?
Yeah, so they come in to our office, and if we acknowledge that there's a need for vascular intervention, we immediately get on that and get them referred there. So sometimes they end up in their office before, and they have a wound and they have a vascular problem, they get that fixed. But I would say that a huge amount of my patients do end up having a vascular intervention of sorts at some point. If we're talking about lower extremity wounds, obviously I have wounds that come from also other specialties like plastics and derm, post-skin cancer incisions like post-Mohs surgeries. Sometimes we have C-section mothers, we have burns. So vascular wounds are not the only one, but a lot of times we get to then address those problems that are already existing in these patients. And I have to take this opportunity to thank Dr. Chuback, Dr. Gloviczki, and Dr. Iker for doing the work that you do. I have been listening to the podcast, and this is such an incredible avenue for us to not feel alone in where we each practice. Sometimes we feel like we're, dealing with these issues that are very rare But then when you meet another specialist who deals with that same problem, it is so fascinating. There's always so much more to learn. So thank you so much for spreading that knowledge. And I feel so fortunate that I get to learn from you all, and Dr. Melin as well. Just incredible brains you all have.
Vein Formula 1000 and Lymphatic Formula 1000 from VitaSupport MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
You're quite welcome. It's certainly our pleasure, and the invitation that Dr. Iker held out, of course, holds true for myself as well, and you, Dr. Melin as well, and Dr. Gloviczki. You can email us, call us, etc., with any questions you might have or advice you might need on patients, and we'll expect that we could call on you too for your advice.
Oh, please, absolutely. If I can be of any help, I'm happy to.
Yeah, I think it's a beautiful thing that you're doing there in your community. Extremely important. I think that wound care is still obviously an enormous problem in the country and around the world. Many wounds are neglected. One of the subjects you brought up earlier, many wounds are hidden. I still remember many years ago, a 36-year-old patient, I was called to the emergency room, and the consultation was for amputation, to just come and amputate the patient's leg. Of course, as a vascular surgeon, that wasn't a high priority on my mind. On my way to the emergency room, I wanted to see what there was to see, but it was a gentleman, 36 years old, very nice guy, remains my patient many years later, who had a circumferential, what we used to refer to as apple core lesion around the entire circumference of the lower leg, just long-standing chronic venous ulceration with untreated underlying venous disease, etc. And was a very, very challenging case, but extremely, extremely gratifying. I mean, here's this young man who has been told, we've called a vascular surgeon because the wound was badly infected, very malodorous, highly infected, and so forth. He was an obese young diabetic, quite sick, and we got him through his hospitalization and then out of the hospital. I took care of him as an outpatient with his venous interventions, debridements, wound cares, etc., and got him healed. But the reason I think of him is because of something you mentioned earlier, which was it had been years. I mean, this is a young man he had an adolescent age daughter and a very lovely wife who would come to his visits with him. His wife had not seen his leg in 5 years, and he was convinced that he had a malignancy, and he was hiding it from everyone. And as you know, with a chronic wound like that, he could have developed a malignancy, squamous cell, etc. He did not, but he had no idea that his problem was chronic venous insufficiency, and that was the source of his wound, etc., etc. And so this idea of shame, fear, self-blame, etc., that when we talked about the emotional aspects, extremely, extremely important. And another case that comes to mind, when I was practicing cardiothoracic surgery, I was called on consultation with a woman who had literally, fortunately, these are rare cases now, but in historical terms, they were not that rare, had basically auto-amputated the breast from a breast malignancy that had ulcerated, and she was terrified and hid the breast, and ultimately she came in with the chest wall, the pectoralis muscle completely exposed and just a rim of malignancy, and I was called in to help, make a diagnosis and ultimately reconstruct the chest with flap rotations that we did together with plastic surgery and so on and so forth. But it is quite amazing how people who develop wounds can become absolutely terrified absolutely terrified. And you could see why. I mean, it's terrifying.
It's devastating.
Yeah, it's devastating. And especially when people are not aware of what's going on. And again, it brings us back to the importance of this program and people like you and sharing your stories and sharing what you're doing. And hopefully we reach someone out there who may be terrified, who may be suffering from a wound, who may be suffering from lymphedema, lipedema, et cetera, and be in the dark and feel, as you said, even as a practitioner, it's easy to feel that you're all alone, that you're the only one doing this, that there's no one else interested, there's no one in your corner. So I think it's very, very important what we're doing together in this program. And we certainly appreciate your being with us today, and we'd love to have you back again in the future. As our time comes to a close, I want to bring it back to Dr. Gloviczki, perhaps for one final question or comment, and then Dr. Iker, and then Paul will wrap us up. Monika, anything?
Yeah, of course, there's always something. My question, well, I have two questions. First of all, I would like to know if you, as a person who lived for a long time in Finland and now in the United States, if you feel the difference in the frequency of wound or a vascular problem, or is that all the same in both countries? That is my first question. And the other question, if you are treating the venous patients with some of the venoactive drugs or supplements.
I think I have heard over the years several times that Finland is the second most American country when it comes to health problems. So I think that the health problems are very similar, and the increased frequency currently of diabetes and cardiovascular problems is very similar. So in that standpoint, I do feel like there's similarities. However, I'm sure you and I and Dr. Iker could speak one full day on the differences between European healthcare in general, just because we do have the public healthcare there and the way kind of that steps in managing chronic conditions. So to me, for example, hemodialysis, and my patient in Finland was on hemodialysis, had been on hemodialysis for 30 years. It's almost unheard of here. When I arrived and spoke with a nephrologist, it was just so surprising to them, just because the chronic conditions are managed so differently, so the financial burden isn't there. However, I think that the acute management of wounds and the endovascular interventions, it is not quite as advanced over there. So I want to be right here when it comes to that. Now, do I treat my patients with those drugs? No, I do not. I actually kind of got certified in wound care at a time when we were finding more and more that it is questionable whether all of those ones are helpful. I usually get them evaluated by a venous specialist to even consider whether they are a candidate for venous intervention, and that is something that we probably didn't even speak about enough, because it's definitely helpful for my patients to undergo that just as well as the arterial side. However, the group where I refer, they often prioritize the arteries and then work on the venous. But we see the wound improving still significantly when we move to the venous side, and that's where I think that us stepping in and trying to fix the nutritional side, and that I definitely put my patients on high vitamin D, high vitamin C, as well as the lymphedema supplement and zinc. And I try to push, if I don't sound like a salesperson by this point, I do try to get them arginate or Juven as well to address all of those.
I want to say that I think that you can play a very important role in that community, bringing greater awareness to the role that the micronized purified flavonoid fraction plays in wound care. Dr. Gloviczki has been instrumental in bringing that data and information to the forefront, and we can share some of that data with you, some of those great articles, because the role of MPFF, especially in venous ulceration for long-standing and larger venous ulcers, the data has been supported now and promoted in the Handbook of Venous and Lymphatic Disorders from the SVS, American Vein and Lymphatic Society, American Venous Forum, and Dr. Gloviczki has expertise there. And we'll share that information with you because you can continue to influence the other physicians, surgeons, vascular surgeons, general surgeons who are involved in venous disease, how important that is. And we want to help you to understand that and to share that. It's of critical importance that we continue to get the word out. The other thing I was thinking about for you, a little bit not off subject, but I wasn't planning to go down this road, but as I'm thinking about your practice, one thing you may consider would be to bring in a good registered vascular technologist, ultrasound technologist into your own practice to evaluate both the venous and arterial systems, so that you could make more of a diagnosis yourself, because too many times venous patients are missed. Arterial patients get picked up because of all of the signs of ischemia, pulselessness, pallor, and so on and so forth. And the focus when it comes to wounds in the lower extremity is often the arterial system, when even vascular surgeons are not well versed in the area of venous specialty. The venous ulceration can be misdiagnosed and then mistreated. So it would be something for you to think about as a practitioner, to bring in a good.
We actually have a business that comes, a technologist that comes to our office and does arterial ultrasound. So that has been amazing. That is in my office in Flagstaff. So it has been extremely helpful when we need that arterial ultrasound and just to get an idea. She's very talented. She also works at the hospital and started her own business.
I think that's a great start, but I'll also say you yourself should consider, I know you have a lot on your plate and so many certificates and so forth, but you can think about getting the RPHS degree for registered phlebology sonographer. And Dr. Iker, I'll bring it back to her for our last comment or question, because she can tell you, as I can, as a clinician in the clinic every day seeing patients, to have an ultrasound of your own in your own hand as part of the physical examination today, I think is an essential part, as essential or more essential than a stethoscope, for example. So Dr. Iker, would you like to talk about your use of ultrasound and how you think Annika might implement that in her practice?
For every patient who comes for a consultation, I do ultrasound. And for example, today I had a lovely lady who unfortunately had very challenging course post-mastectomy, where the implants were infected with Pseudomonas, and she had massive infection and so on. And now she came with a questionable left upper extremity lymphedema. And when I examined her, I looked at her and I said, "You have lipedema to start with." And she said, "What are you talking about?" Okay, so observation is very, very important. So I pulled the ultrasound and I evaluated her left upper extremity, where she thought it was more swelling there, and she thought it was, and she was told she had lymphedema there, and it was clear cut, just lipedema, not lymphedema. And if I would not do the ultrasound to confirm that she does not have lymphedema, she would go on her life with, "I have lymphedema in the arm." So ultrasound is it's very important tool, and it's not only for this patient. On the other hand, I had very slim young lady, 50 something, and looking at her, she looked slim, but when I did ultrasound, she had lymphedema in her distal lower extremities because previously she had uterine cancer. And so it is so important to use the ultrasound and to confirm the clinical presentation, or objectively to assess, does the patient have this or that, or what do I see? I don't do the venous studies, because usually the patients already either come with on board with results of something, but I do more the subcutaneous tissue for assessment of the lymphedema and lipedema. And I think, what was it, the Lymphatic Education Research Network asked me to give a talk, and it will be, I think, in April, where I will go through the diagnosis and how to establish and how to treat swelling in, I will focus on lower extremities. And coming to that, maybe, John, we should do a workshop.
Yeah.
And a workshop to assess the clinical presentation with diagnostic or ultrasound study. And then what do we do? How do we treat the patients when we have this or that, and so on? So that's just
I'm signing up.
I think this has been one of our goals eventually, to put together a workshop through the LymphCast group, and I think it'll be quite remarkable if we consider all of our guests and the people that we could involve. Well, all I can say is it's been a fascinating hour. I've really enjoyed it. I've learned a lot, as always, and I am going to pass it back to Paul Reeves to wrap it up and say goodbye and say until we meet again, Annika. Until
Correct.
we meet.
Thank you all so much. I really enjoyed it.
All right. Before I go around the table, Dr. Chuback, do you want to officially thank? You just thanked her, but you want to even thank her more for all that she's done for today's show?
Of course. I would like to thank our guest, Annika, for her wonderful participation in our show, and more importantly, for the wonderful work that she's doing for the people and the community of Flagstaff, Arizona, and in the area around the Phoenix, Arizona area. Congratulate her for her hard work, her academic pursuits, her training, her degrees, her interest in a very challenging area of medicine, but an area of medicine that I also believe is one of the most gratifying. As a surgeon with vast experience in general surgery, vascular, thoracic, cardiac, etc., I have to say few things compare to the feeling of healing a wounded patient. This is a great, almost ancient sort of experience for the physician, for the quote unquote healer. And of course, all practitioners, nurses, therapists, I include in that group of those of us who have committed our lives to making other people well. But there's something quite remarkable about healing a wound, especially a long-standing and chronic wound. So I congratulate you for your work. I thank you for being with us today, sharing your story, sharing a small part of your life, sharing what you do. And I know that we'll all be in communication again in the future. And we're here for you. And I know that you're here for us, and you're here for your patients, and we're here for your patients in any way that we can assist you in that community. So thank you once again.
Thank you. They are very lucky to have you all.
All right. Thank you, Annika, for everything. Let's go and thank our panel from Arizona, Dr. Monika Gloviczki. Dr. Gloviczki, once again, thank you for everything, and go out there and have a great night.
It's always a pleasure to be with all the team, and of course with our guest and Annika today.
All right, thank you. And from California, we have no sympathy for the fact that it was 41 degrees today, Dr. Emily Iker.
Thank you all. Thank you, wonderful team. And thank you, our special guests. And my greatest compliments for your challenging work. Continue.
All right, thank you. And the founder of Vita Support MD, makers of Vein Formula 1000, Lymphatic Formula 1000, physician surgeon from New Jersey, the founder of this show as well, Dr. John A. Chuback. Thank you, Dr. Chuback, for everything.
Once again, thanks for being here, and we look forward to the next program. Share it with all your friends. Tell us about us. Thank you.
All right, thank you. And again, it's been a LymphCast, episode 18, podcast page, YouTube, we're all over the place. And join us again next time for LymphCast, episode 19. Thank you, and have a great day.